Welcome to In the Thick of It from the HCM Society, a show that dives deeply into hypertrophic cardiomyopathy with leading experts in the field. We explore groundbreaking research, new approaches, and other exciting topics. Please enjoy today's discussion supported by an unrestricted educational grant from Bristol Myers Squibb.
Hi, everyone. Welcome to In the Thick of It, a podcast that focuses on hypertrophic cardiomyopathy and interesting topics surrounding it. My name is Dr. Florian Rader, and I direct the Cedars-Sinai HCM Center. And I am very excited to welcome my guest today, who is the legendary Dr. Ahmad Masri, who is my counterpart at OHSU in Portland. Hi, Ahmad.
Hi, and thank you for the kind introduction. I'm very happy to be here.
Yeah, great. So we have a really interesting topic today. We chose the MAPLE trial. The MAPLE trial, I think, was a very transformative and informative trial that really gave us a lot of new clues in terms of what's the ideal treatment for obstructive symptomatic HCM. Ahmad, maybe we'll start with you explaining our audience a little bit about the goals of the study. What clinical question did we try to answer?
Yeah, I fully agree. MAPLE was a very ambitious trial where it's not very common, as you all know, where you take a standard of care that's been used for many decades and you challenge it. Because when you do active treatment head-to-head, in a multi-center settings, in a highly controlled settings, you actually don't know what you're usually going after. I think we already know that aficamten is very effective. That's based on the Sequoia HCM trial. That all was known, but what wasn't known is what will be the behavior of metoprolol as a representative of beta blockers, and this was metoprolol succinate. What would be the behavior of it? Because as you know, a lot of trials, don't do well because of the placebo behavior. And so this is really what you're trying to test here. And so in this trial, metoprolol was used as the comparator. Patients were randomized 1-to-1. About 180 or so patients were included. And the primary endpoint was peak VO2. The trial was conducted in a complex fashion because you don't want people to be able to guess what the patient is on. You want it really to be truly a blinded trial. So you had, what's called the double dummy design, that the patients will take placebo for each drug, on the other side. And so if you're on metoprolol, you have placebo for aficamten. If you have aficamten, you have placebo for metoprolol. And the PIs were not aware of the vital signs of the patients unless clinically indicated for whatever reason. Because at the same time, you really don't want that to become an unmasking event on its own, usually. And so you end up putting these numbers and these data into a web portal, and you're not involved as a PI, someone else in your team is, and the titration and the continuation of the treatment happens that way. So that was the background of the trial.
Yeah, and I think that's true. And do you think that blinding did actually succeed? Do you think patients and investigators were fairly blinded to, I think the overall average heart rate was lower, of course, in the metoprolol group. Do you think people were aware of that, or?
So you could guess maybe, but you wouldn't be able to confidently say that someone is on this or that, because we gotta remember that what we see on average is not what happens at an individual level. So this is similar to NT-proBNP, where we always say, oh, I can tell if someone is on, a CMI based on that. That's not true. At the individual level, there is so much variability when it comes to these measurements. At a group level, obviously, yes, you see the differences. But that's exactly why the trial design was done in a way that, you shouldn't really, as a PI, because in any trial, as a PI, you can dig deep and try to unmask, but that's not the goal. You shouldn't be a PI if you end up taking a randomized clinical trial and work hard to unmask yourself. And really, this is a short trial, so it's not like, there is a life or death situation happening and you have to force this to happen.
Absolutely. And I agree. And being an investigator and having several patients in that trial, it wasn't clear to me always which treatment they were on, even though maybe there could be day-to-day variations of heart rate and so forth. And the titration in that trial was fairly aggressive, right?
So this is a decision that you have to take ahead of time. If you look at the average doses of metoprolol used, in most claims data and in most approaches, they actually usually are in the intermediate to high range. And so we usually would consider 50 and 100 of succinate to be on the, lower to intermediate range, and would consider 200 and above to be on the high end of the spectrum. And so that's why the trial was designed to have metoprolol range dose succinate of 50 to 200. And 60% achieved the 150 and the 200, which are the high dose. So the trial was fairly balanced in the distribution of patients, 50, 100, 150, 200. And more data will come out on that. But ultimately, I don't think you can take a drug and cap it at a low level in the absence of data or information, because then your trial actually is not applicable. Because if you're taking an effective drug and you're comparing it to another drug where you don't use enough of the drug, then it would have been the other way around. How do you design a trial where you only are using the least minimal amount of dose that is even available to individuals?
And there would have been criticism then, of course, of that if we didn't use appropriate doses. So that was an interesting aspect of this trial, I think. Tell us about the outcomes, the results. What do you think were the main salient findings here? I mean, obviously, aficamten performed very well, right?
Correct. And as we mentioned, we expected that to be the case, correct? I don't think anyone would expect to go now into an obstructive HCM trial and you're going to not see what you've seen before. I think the unexpected finding is that metoprolol resulted in a significant reduction in peak VO2, which is the primary endpoint. To be exact, it was minus 1.2 ml per kilogram per minute, which is quite a lot when you put it into the perspective of the baseline value and the percent change. And also, which to me I think is very important because it speaks to us of clinical day-to-day practice, is that it worsened NT-proBNP. And if you look at the figure, it looks like it's in a dose-dependent fashion. It also worsened left atrial volume index. Both of them are markers of stretch, markers of serious, remodeling and worsening of typically obstructive HCM. And this is at the population average, not even just an individual level. And then I think the other takeaway point is that once you actually challenge these drugs, like metoprolol was not well tolerated. You've had to do frequent down titration. You've had to do frequently taking patients even off metoprolol. And it was an exclusion criteria in the trial that if you had previous intolerance to beta blockers, you couldn't even be in the trial. So those are not like patients who just like are randomly being chosen. Actually, if you had any history of that, they would be excluded from the trial. So I think all of these are important findings. And then, there is some critique, obviously, that, well, peak VO2, you'd expect it to be affected by beta blockers. But, Greg Lewis presented this 16, 17 exercise metrics. No matter how you slice or dice it, you actually do worsen with having metoprolol or beta blockers on board.
Yeah, exactly. What was also incredible to me was the minimal effect on outflow gradient with beta blockers, which really flies really into the face of what people have done now for decades and decades in this disease.
That's what you end up with when you don't think about drugs as responder analysis only. Once you start taking all comers and evaluate what happens to them, that's why you would end up surprises, because in the clinic, we think of responders versus non-responders, and we present our positive experience saying, oh, I had, 20 patients, 15 of them did great, and I, this and that. But that's because you're only subselecting usually for the responders, while if you take all the population on average, we do get surprised. And also to your point, aside from the LVOT gradients themselves, not getting reduced with metoprolol with beta blockers, this also got applied even if you had no previous exposure to beta blockers. So it's not like 75% of the population had prior exposure and they got washed out. But even in the subgroup that has never been exposed to beta blockers before, the results were consistent still.
Yeah, which is also a little bit of a critique that I've heard about this trial before, is that we sort of subselected patients who already failed beta blockers before, because most of them were treated with beta blockers at screening, and they had symptoms. So they sort of failed beta blockers. So did we select a group that sort of already was known to not do well with beta blockers?
Well, I'm not so sure because ultimately, if you end up with a trial of 180 patients, a quarter of them have never been exposed to beta blockers before, and you really don't have a signal that, you have clearly failed in any of your subgroups. I think that's the point. If you look at the forest plot, in every single pre-specified subgroup, there is absolutely nothing to see, no matter which subgroup you look at, including previous exposure to beta blockers or not. If it were true what this, people say about this, you washed out a lot of patients of beta blockers, so they quote unquote failed. If it were true, then you would have seen that heterogeneity of effect actually emerging. And, it wasn't. And if the trial was underpowered to detect that heterogeneity of effect, then you would have seen a lot of these secondary smaller subgroups not behaving in the same direction. Here, the directionality, the point estimate, and the confidence interval were all on the right side, essentially, of the figure. None of them were not. And so I think that's a weak take in general. And then finally, I would mention that, most of the time in clinical trials, whoever you select reflects your beliefs and your approach to things. And that's why we need multi-center trials. When people come and say, well, this is divergent from this single center study that was done, because that single center study has so many characteristics that reflect on you as an investigator and on you as a site. That's exactly why we run these multi-center studies, because the heterogeneity is just really, really high.
Absolutely. Yeah, it's so important for clinical trials in general. So maybe before we completely say we should not use beta blockers in obstructive HCM anymore, any upsides of beta blockers in this disease, or why would you still use beta blockers in this patient group?
Yeah, I think what this trial showed is that you shouldn't be using beta blockers and pushing them for the sole indication of reduction of LVOT gradient and improvement of symptoms. Now, that's, I think, the takeaway. Now, if you have someone with AFib and you like to control their rates, we can argue if it should be rhythm control or not, that's a different story. But let's assume that you gave up on rhythm control and you want to do rate control. If someone has coronary artery disease, if someone has it's unusual, but it happens, like a larger LV cavity, and they have like kind of almost a mixed type of a cardiomyopathy, not your classical small LV, HCM. There are certain scenarios where you could or you might have to revert to a beta blocker. But I think what the trial showed is that for the first line indication of improving symptoms, feel, and function and gradients in this population, I think this is pretty as strong of an evidence as it gets, really, in that scenario.
Yeah, I would agree. And honestly, even me, sometimes I feel, well, maybe I should give that patient a little bit of metoprolol, even if they are on a CMI already, just for that antiarrhythmic effect. They have some NSVT, but the data showing that it actually helps that problem, or definitely not prevents sudden cardiac death. It's just not there, right?
Yeah, and the takeaway for me, we are in 2025, we should really reevaluate everything that is set in stone based on expert consensus. There is absolutely no excuse nowadays of not challenging any of these things. I mean, the heart failure community got to this 25 years before us, correct? So they started early on from the beta blocker story. Beta blockers were contraindicated in patients with acute, with heart failure. And in the acute settings, you have to get rid of them, never initiate them, do this, do that. And then they showed in trials that this is not true. We're essentially following in their path, but much, much later, in the sense of you cannot just only use physiology, pathophysiology, biological plausibility, as well as experience as a way to give class 1 and class 2 indications of drugs. You can stay silent on them if you want, but ultimately to give strong recommendations based on anecdotal experience, I think it's time to move away from that.
Absolutely. And it's an exciting time where now finally we are in an era in HCM where we have adequately powered trials. We have multi-center trials. We have HCM centers of excellence where we actually have enough patients to test these theories. So really cool. I think we're at the end of our time. So thank you for a great conversation. Very informative. And my last question maybe is, do you think the guidelines will change?
That's a tough question because, the guidelines, ultimately, they cannot ignore the evidence and they really have to take it into account. I think the guidelines were critiqued before when that change with mavacamten occurred, that you have a drug with 2 phase 3 clinical trials and it was placed at the same level as other interventions that have no strong evidence aside from, clinical experience and anecdotal experience. And so it's very hard to know essentially how things will go, but it would be a disservice to the community if this trial does not get the proper and appropriate assessment and evaluation. And even if there is reluctance to totally remove beta blockers from the story, at least you can modify the language, you can modify your take on this, you can tone things down, and you would elevate aficamten. And what the trial also, forget metoprolol for a second, what the trial proved is that you can use aficamten as a single upfront monotherapy agent, which wasn't known before. I mean, we take this for granted, but it actually was not tested before. And so that's another piece there that is important.
Yeah, I think the safety of this story is also important, really. All right, well, thank you so much, Ahmad. Great seeing you and talking to you.
My pleasure.
Thanks for joining us on In the Thick of It, presented by the HCM Society. Make sure to subscribe to our show for more expert insights into the field of hypertrophic cardiomyopathy. For more information, check out the links in our show notes. We hope you will join us again for our next episode.